Are you okay? We're okay. If he's okay, then we're okay. All right. Okay. All right. So, okay, I can't mark it, of course, but you'll understand that we are talking about the midpoint of the sternocleidomastoid muscle. So it's about here. So if we can put the electrodes as well. Okay. All right. All righty. Okay. So you can go ahead and place the electrodes. So we place the active electrode here on the middle of the sternocleidomastoid muscle. So measure the head, the position first around here. Okay. No, okay, clean that first. And then on the middle of the clavicle. We'll set it up, and then you can come up and have a look, okay? So we'll put the electrodes first. Okay, so we'll take the active electrode now.
You want to put it on the forehead or in the
Forehead is usually my habit. Sorry, can you do this for me? Here.
So it is coming on monitor.
Okay, good. All righty. So this is the active electrode, okay? And then the reference is here on the clavicle. In the middle, on the bone. Very good. And the ground is on the forehead, okay? Sorry?
Clavicle, which is middle.
Yeah, in the middle. That's what usually, yeah, yes. It's not critical, but as long as it's on the clavicle, okay? Okay, then we can connect that, the ground. Oh, good, okay. So this is the setup as I showed on the PowerPoint presentation earlier. It's a very simple setup with the active electrode in the middle of the sternocleidomastoid muscle, the reference electrode on the clavicle, and we have the habit of putting the ground on the forehead. So if you haven't done it already, go ahead and place it on the forehead. It's an easy place to place the ground electrode. Okay? So it's a very easy setup. Okay, so we are just getting ready waiting for the system to get started. Since we're waiting, since we did not have during the presentation, do you have any specific questions with regards to VEMPs? If you want to ask me now while we're waiting. Yes. Say again, sorry? Yes. Yes. So you're talking about endolymphatic hydrops in general and VEMPs in general. Okay, I'll show you examples of that tomorrow with regards to the presentation on clinical applications. And I will show you several examples of patients who are under investigation for Meniere's disease, endolymphatic hydrops, who are known to have endolymphatic hydrops, who have better responses at 1 kilohertz compared to 500 hertz. This difference in amplitude at these two frequencies is indicative of endolymphatic hydrops. Okay, VEMPs are usually better at 500 hertz. Okay, by finding a better response at 1 kilohertz, is indicative of endolymphatic hydrops. Now, this is where I won't have time to go into this, and this is an opportunity to mention this while we are getting ready, is that, yes, you have the protocol that I described about how to do VEMPs, or CVEMPs specifically, using 500 hertz, 90 decibels, 110 decibels clicks. But if you have a specific differential diagnosis, you should change the protocol. One example is Meniere's disease. So if you have a referral letter from your colleague mentioning that they want to rule out Meniere's disease, you don't just do VEMPs at 500 hertz. You should also do it at 1 kilohertz and compare the two. Okay? So you may not get an abnormality at 500 hertz CVEMPs. It may remain normal. And I will show you an example of a case tomorrow where at 500 hertz, the responses were normal. But when I did the 1 kilohertz, on one side, the CVEMP got better. Okay? I don't want to spoil the surprise, but I think that answers your question. Where using a different frequency and a better response confirms Meniere's disease compared to, for example, vestibular migraine. But we'll go into this detail tomorrow. Yeah.
That is a specific sign for endolymphatics as it changes in the frequency tuning of cervical vein. But present, enlarged, absent, something, it's not very specific. The specific sign for endolymphatic hydrops, as my friend told, is the changes in the frequency tuning. Normally, the best response obtained by 5 hertz tone per rest. But in Meniere's disease, the best response got to higher, shifted to higher frequencies, usually 1,000 hertz.
I still waiting.
So to do 500, 1,000. If you got absent response or weak response for 500 and good response for 1,000, that's suggestive of endolymphatic hydrops. In superior semicircular canal, it's different if you are doing CVEMP and OVEMP. For cervical VEMP, I think the threshold, he has a great article. I recommend you that you go for the guidelines article he wrote. It's one of my favorite. And for superior semicircular canal dehiscence, not the enlarged response, but the threshold. The decreased threshold is the specific sign. Decreased threshold.
Yes. Yes. Enlarged vestibular aqueduct syndrome. I think the findings are similar to semicircular canal dehiscence.
That's
third window phenomenon. There's not third window, but you get a potentiation of the response with, in these cases.
in congenitally deaf children, you expect that they have associated congenital anomalies or deficit of vestibular system. But in enlarged vestibular aqueduct, you have a deaf child, but with very good or enlarged VEMP responses. This is mainly because it works to some extent as a third window phenomena. The same mechanism as third window, it's also present. So in most of the congenital disorders, you expect absent VEMPs, except with enlarged vestibular aqueduct. If you have a deaf child with good C-VEMP responses, most probably he has enlarged vestibular aqueduct.
Okay, so we're ready for the demonstration.
Okay.
I thought, is it possible to connect the monitor up there? Or will
Yeah,
people come up?
no, it's connected.
Maybe on the
change
one
that.
monitor, if we can do that.
Laptop connection.
Yeah. That way we can have the... Tell the patient in this time, in this case the volunteer, is to lift the head up such that they just don't feel the pillow below the head. That's all you need. You don't have to lift it too much, okay? And this helps in elderly patients as well. You only have to contract the muscle a little bit and you'll get a good response. So, are we ready? Okay, lift your head up just a little bit. Okay, start the averaging process.
It's coming.
Can you decrease this display?
Can it?
What?
Okay, relax.
I've taken 300. I'll take 100.
Well, stop the... where's the response? 13 milliseconds. What's this line?
This is 20.
Okay.
And this 17,
Okay.
13.
13. So it might be this response here.
So it is not proper, that's why. So I'll take 300 limits or limits 200 or 100. What is recommended for that?
For 100. You can use 100. 100 stimulations. Let's do a second trace.
I'll show you the settings first.
Okay.
501 first.
Mm-hmm.
Asking I'm using my refresh.
It could be. So if you can do a second trace as well. Okay, so it might be this response here, but we need to confirm it by doing a secondary recording. So are we ready? Okay, so yeah, lift your head up, start the averaging process.
Yeah, this is.
Okay, stop. Stop the. Can you superimpose the two responses? Okay.
Yeah, that's look.
That's good, but it's 18 and it should be on this only.
Yeah, it might be this one here. Yeah.
I suggest the opposite.
Yeah, actually it's came like this only, but our latency is very early.
No, it's it will be 11 or 12.
It's 11. So we'll put it here.
Yeah.
Okay.
So this is P. Yeah.
Repeat it again and get sure.
Is positivity upwards?
Actually, I used to get positive in that way. That way you sold. No?
So this is how it should be. The positivity is upwards. Okay. Okay, let's do a third trace.
You can repeat and get sure.
We can replicate. We'll see.
Yeah, we'll do a third trace. Let's repeat it.
I'll see the impedance first.
Okay.
One of the clinical tips, if you have a evoked potential system without a dedicated platform for the VEMP testing, is just to adjust the display, because VEMP response is much more than the EBR response. So maximum EBR
Okay, so let's
response
clean it
is
then.
500 microvolts, but for the VEMP it's by millivolt. So if you use a system with a non-dedicated platform for VEMP testing, and you just change the settings for the EBR protocol, be careful to change the display setting, because you have to make it much higher, because it minimizes. Otherwise, you just have this nothing clear, because it doesn't come to the display. So this is some systems. You can't recognize any responses unless you have changes the display parameter to like 10 millivolts, 10 millivolts per division, and instead of 0.3 microvolts for the EBR. So this is, if you don't have most of the systems with a dedicated platform for VEMP, they adjusted the display settings.
Looking for impedance. Yes.
We're okay?
Yeah.
All right, okay, so let's do another trace. Are we ready? Okay, we'll do one more recording as well, one more trace. Okay, so lift your head up and start the recording.
This is for what? This is display or what?
This axis.
Yeah, make it higher.
Okay, stop the averaging. Relax.
Show better.
Okay, yeah, stop the recording. Okay, and let's see what the other traces look like. Okay, remove this third trace. Delete this one here. Yeah, this one here.
How many sweeps did you take last time?
Sir?
How many sweeps? How many repetitions?
3-4 times I've done.
No. The number of sweeps.
Number is 100.
100?
Okay, so delete this final trace.
What I'll do? Even as
This one, just delete it. Delete the whole line. Can you do that? Can you remove this?
What I'll do?
Yeah, to get rid of it. I only want to see this and this. Yeah, yeah.
Delete that third.
So positivity is upwards, yeah? This is true. Okay, so for the sake of time, we'll stick with these two traces. You need to do 100 stimulations. I don't have a pointer. Do I have a pointer? No, I don't. Okay. All right. So the response is this here. This one here. This is the CVEMP response. It's a little bit smaller on the first trace, but for the sake of time, we are averaging the response in a limited way, so not to spend too much time on this, so it doesn't interfere with the other group. But this is a larger response here on the second trial, where you have a CVEMP response, and this is, you take the first positivity in your recording that's reproducible, and this represents the CVEMP. Now, this looks differently from my presentations, because on the systems that I use, positivity is down. Okay, in this specific system, positivity is up. So don't get confused about the shape. Usually positivity is down. Most evoked potentials have positivities down. The BIEP, all the waves are on the top part of the waves, or there are some laboratories that measure it at the bottom. But if you have it like my system, where the positivity is down, then it'll be like my waves. In this case, the positivity is up. That's why it looks different. Okay, but the wave is the same. Okay, the wave is the same. My suggestion is to have the positivity down if you can, because this is what most of the literature presents. Okay. How much time do we have in regards to the rest of the workshop? How much time do we have? How much time is left? Sorry? We have another half an hour? Good, okay. So we'll do the OVEMP as well. Sorry? So we have to finish in 50 minutes. Okay, no problem. No problem, okay. So we'll do the OVEMP as well. So we will stick with this ear, stimulating the right ear. But as I said in my presentation earlier, the OVEMP is a crossed response. So we are stimulating again the right ear, but we are recording below the left eye. Okay, so the OVEMP is a cross response for utricular function. So if we can take these off then. Oh, you want to use another electrode? Okay, all right. So we're going to place some electrodes here, okay. So, I'd like to remind you with regards to the ocular vamp, the recording electrode is placed, you find the orbital ridge, where the eyeball is located, the orbital ridge, and you place it in the middle. And the reference electrode is below that. The literature talks about 2 centimeters, 1.5 centimeters. You're not going to go ahead and measure and take a ruler. As long as the reference electrode isn't touching the active, it's okay. Okay. As long as it's below, but not touching the recording electrode, so there's no salt bridge, and you can have the ground electrode on the forehead. So you prefer this because it's smaller? Oh, okay, all right. Yeah. I use that for the sternocleidomastoid as well, so I have the same electrodes. Yeah, it's okay. The positions are fine, yeah. Yeah, this is where, yeah, okay. All right. Yeah, this is the active, yeah. This is the active here. That's on the orbital ridge. Okay. So again, a simple setup, 3 electrodes placed in a different position on the head. Yeah, we can keep the ear the same. So stimulating the right ear and recording below the left eye. So you can check the impedance as well for this. Yeah. Okay, it looks a bit loose, so we need to fix it. Yeah, it looks a bit loose. Or put the electrode with a separate tape, perhaps. Okay, get a new electrode. Okay, all right. So things that can happen during the evoked potential examination. Okay. Sorry? Kilo ohms, you mean? That's okay. If it's 3.2. Okay. All right. So we start the recording then.
You want 500?
Sorry?
500?
500 hertz. Yes, 500 hertz. Yes.
Any rate? Particular rate?
Five. Yeah.
Condensation or alternating? Condensation?
It doesn't matter. I mean, studies haven't shown a difference. So if you were to ask me, if you were to force me to choose, I would choose condensation.
Okay.
But the studies haven't shown any difference.
Will do?
Okay, so what I forgot to mention is the when you use tone, is it a specific tone stimulus? Is it tone pip or tone burst? Tone burst, good, yeah. Burst gives the impression that you're using force. Okay, so are we ready?
Yep.
Okay, what I want you to do now is to look up. Okay, start.
Like that?
Yes.
Laptop.
Using these three at the bottom here then?
Right here, right, I already have not mentioned.
Okay, so it's good. Okay, all right. We'll start again then. We may be picking up artifact in the room. Okay, so let me straighten the electrodes out. Okay, this is a bit small. Okay. It's coming through. Okay, so stop. Let's get started. Erase it. You ready? So is it zero? You've stopped. You've erased it. So is it ready? Okay, all right, okay. Okay, so erase the previous recording. Yeah? So there's 50 hertz coming through. But the impedances are good, yeah? It must be the room then. Yeah. Huh? Yeah, well, let's try it. So are we ready?
Yeah, it's coming, but I don't know why the former flow is not coming. Look now.
Well,
Yeah, now it's coming.
okay, all right. Start from beginning. Press erase, and we start. Okay, just a moment, just to relax. Tell me when you're ready. Are you ready? Okay, just a moment. Okay. Sorry, I need to stand here. Okay, look up and start the averaging. Stop the average. Okay, relax. Let's see what we've got. So this is the response. It's 50 hertz. Yeah, it's 50 hertz. No, it's not the response. It's 50 hertz. Okay, all right, okay. Are we up for time? Is the end of our time now? So how much time do we have? It's finished. Okay, so this is what happens sometimes. At least you saw the C-VEMP. It appears that we're picking up 50 hertz somewhere in the building, okay? So this is 50 hertz. This is not an O-VEMP response. Maybe we'll have better luck in the next group. But this is the setup for the O-VEMP. And we should have got an initial negativity, which in this system would have been a sharp peak going downwards, okay? So I've been told that this is the end of the work of this session, and then you have to rotate now. Do you have any questions with regards to this? Yes. Just a moment. Is there a microphone?
Hello. Cases when you cannot find the sternocleidomastoid muscle, which place you exactly pick it up?
Why would you not find it?
If there's 2 minutes of skinny people, we try to move around, but we cannot find
You lift the head up.
Okay.
You'll be able to feel it. There's no
Yeah.
doubt about it. You will find it, even in thick muscle. Do you do somatosensory potentials?
Yes.
Okay, somatosensory potentials. You have the patient come along, and it's all fats here. How do you find it? You ask the patient, they're usually sitting down when you put in the electrodes. You ask the patient to push your hand with their forehead. You may not see it, but you will feel it.
Okay.
It's the only muscle that will get contracted during this maneuver. And this is the same with the lying down. You ask the patient to lift up the head. You may not see it, but you will feel the muscle going down. Okay? You'll be able to find it.
Okay.
There's no reason not to find it.
Yeah.
Do we have the microphone? Can we,
One more question, sir.
Yes, go ahead.
We usually place the electrode on the sternum, but you placed on the collarbone. So what?
The collar is the reference. Yes.
No, we place on when we do it on the sternum, the midpoint.
The reference.
Yes.
Why'd you do that?
No, we have been taught before in our college, so we start doing that.
Read my guidelines.
Okay.
The international guidelines. The reference goes on the clavicle.
And if you're changing place, the electrode also to change the other side.
You change sides, yeah.
From even for the collarbone also. You have
Yeah, the reference has to be moved to the
That
other
also
side.
has-
Yeah.
okay. Thank you,
Okay.
So what is the sensitivity and specificity of this test
For which disease?
for any disease? Or and second question, if in
Well, I'll tell you, for example, with the
Menias.
what Dr.
Menias
Pradeep
disease.
told me. Asked with regards to the lymphatic eye drops.
Yes.
Okay. How specific is it? It? At least, I don't know the top of my head, but we're talking about close to 80-90%, because you won't find another condition frequent enough to cause this frequency shift, or called frequency tuning. An increase in intracranial pressure might do that, all right? But you would already know before the patient came in that the patient does not have idiopathic intracranial hypertension. You're trying to rule out disease. So if you see a frequency shift, then that confirms the diagnosis.
And sir, during the Menias disease, because most of the people come after 24 hours in our place. So
They will come, sorry?
after 24 hours after the attack. So would it be the same in the inactive stage or?
I will show you an example tomorrow.
Yes.
The patient is not in an attack,
Yes, sir.
but she stopped her medications 2 days before.
Okay.
They have to stop the medications like with the other paramedical examinations. But the case I will show you tomorrow, she's not in an episode. She came in for evaluation, and you see the frequency shift.
Okay. Thank you, sir.
Okay, thank you very much. I think you're allowed to rotate now. Get started, okay?
So we need a volunteer, please. If anybody wants to learn, you can come. Yeah. Thank you, sir.
Okay, so we will be doing the demonstration here with regards to the. So if you can, fix the electrodes for the sake of time. So we're going to be demonstrating here the vestibular valve myogenetic potentials, starting in chronological, in the order of history, if you like, starting with the C-VEMP, and if we have time, we'll do the O-VEMP as well. So, like I said in the PowerPoint presentation that I gave earlier, the C-VEMP is recorded from the sternocleidomastoid muscle, and it's specific to saccular function. The ocular vamp is recorded from the opposite inferior oblique muscle, and is specific to utricular function. Okay, so, and with the corresponding nerves, C-vamp, saccule, inferior vestibular nerve, O-vamp, utricle, superior vestibular nerve, and the corresponding parts of the brainstem as well. So, what we can do here is you can see the sternocleidomastoid. We're going to show the C-vamp, like I said first. The sternocleidomastoid muscle is an easy muscle to find. From which are we recording from? We're going to record from this side. Okay. Both sides. Okay, so let's find the position of the active electrode first. Okay, so we're going to put it on this side. Okay, so let me show the sternocleidomastoid muscle first. So it's an easy muscle to find. We are doing this in the sitting position. You can do it in the lying down position as well. We had some artifact with regards to the recording. It may have to do with this room here, okay? So we're going to try doing this in the sitting position in the hopes that perhaps we can do both and artifact-free. So you can find the sternocleidomastoid muscle very easy. It's here. So we just place the active electrode in the middle, okay? So that's where the active electrode will go. Okay, so we place the active electrode. Okay, and then we place the reference on the clavicle, okay? Put it on the clavicle. Put it on the clavicle there. Okay, you can relax so you don't get tired. Okay, we don't want you to get tired from now. So the reference goes on the clavicle. So it's a simple setup. Okay, and we can place the ground on the forehead as well. So we are recording from the right sternocleidomastoid muscle. So we'll be stimulating the ear on the same side. We will be stimulating the right ear. The system here has the capability of stimulating using tone stimuli. So we'll be using 500 hertz at 95 decibels above average hearing threshold. 90 is okay as well. We have ear inserts here. My laboratory uses headphones. You can use either one. It doesn't matter. Either headphones or ear inserts, depending on what you're used to doing, especially if you do brainstem autodeveloped potentials, you just continue along the same line. Okay, because we are in, like I mentioned in my talk earlier, in the lying down position, the activation that we choose is to lift the head up from the pillow. Because we have the patient sitting, the activation needed in this position is to turn the head to the opposite side. So are we ready? Okay, relax. Are we ready to, you're recording the impedance now. Well, is it the one that's 7.8, 6.3, and 3? Are you using the 40 as well? Are the 40s included? Okay. You looking for this? You want to clean it a little bit more? Okay, all right. Okay, should be okay. Yeah, one has to be careful of just cleaning here, so it can get scarred very easily on the bone here. Mm-hmm. That should be okay. I mean, you're not using the bottom one anyway. Yeah, but you're not using the blue. You don't have an electrode in the blue. Yeah. Okay. Does all 4 inputs have to be connected for the system to work?
Yeah, I think so.
Okay, all right, so that's okay. The impedance are working. So we're ready to start.
We'll start, then we'll do it once again. Okay.
So are we ready?
Yeah.
Okay, so turn your head towards me. You go ahead, just push against my hand. Push. Okay, start the recording. Stop. Okay, relax. Okay, relax, sorry. Okay, turn this sensitivity down. Okay.
Now we can see nice.
And the positivity is that?
Yes.
Okay. So it appears to be this peak. Okay. But of course, we're going to do another trace to confirm that this is indeed the response that we want. So can we do a second trace?
Once again, we'll do.
Don't start yet until I tell you.
Why it's not showing?
Now, of course, if this is indeed the peak, the positivity here is up. Okay. Are we ready? Okay, right. So let's just a moment. Let me get ready as well. So you ready to start? Okay, push against my hand and start recording. Stop. Okay, show me the two traces together. We'll do a second trace now again. Okay, so we'll do it again. Let me see where this is. This is about 16. Yeah.
It's coming, but why it's not showing, I don't understand. One minute,
Hello.
give me one.
So this is a good response. You know, maybe we can reproduce it. So
Why
this,
it's not coming once again, we'll see. This is one, which is one I think earlier patient. Yeah. So now.
well, we can do a fresh second trace. If you've done, if it's okay, we'll do it again, if it's possible.
We'll do once again.
Yeah.
Okay.
You ready?
Yeah.
Okay. So this is about 60 milliseconds. There might be an interesting point here. Okay. All right. So are we ready? Okay. Turn your head now and start averaging. Relax. Let's erase it to start because I wanted to see it. Okay, so erase it. Yeah, I want to see something because there may be an important point here.
Which one? Once again, I'll start?
Sorry?
Once again, I'll start?
Yeah, I erase the second time. Just keep the first one.
Just give me 1 second, sir.
Yeah, yeah.
Because once we should enter a new setting, right? A new patient. I did this earlier patient. That's
Ah.
not coming. So I'll
Okay, all right. Yes. Mm-hmm. Mm-hmm. Okay. Okay.
Put that into the equation.
It should be like that. It should be the green. Yeah, yeah. No, this is doing. It's not coming actually, but it will come. Yeah, that's it. Sir, it will hold the muscle. It will go automatically to the green line.
Okay.
That means the muscle is appropriately tensed.
Yeah.
You can see that the EMG indicator on the right.
Okay, all right. But it will acquire the signal automatically when it goes into the green?
Yeah.
Okay, so I don't have to look at that then. It will do it automatically. Okay, all right, okay, all right. Yeah, yeah. What's the level? Okay. So we're ready?
Yeah. New pressure.
So we're starting from 0?
Yes, sir.
Okay.
Can stop. Yeah, it will come. Yes. See, what I am doing, sir?
Yeah, now
Touch the nose. Touch the nose. Try to touch the nose.
Ah, okay, all right.
Now see.
All right, okay, all right. Okay, stop the averaging. Okay. You stopped? Okay, relax. Okay, let's see what the wave looks like. Okay, bring it down.
Now it's cancer.
Hmm. Okay, so that might be the response there. Okay.
It's the response.
So the positivity is down this time?
Yeah.
Because before it was up?
Yeah.
It's down this time. Okay.
This is the proper way I'm doing.
Okay, all right, so do a second trace.
Okay. Let's start.
Okay. All right.
Close the eyes.
Okay, start averaging. Okay, stop. Okay, superimpose the two. You seem to be off the screen.
Apply
Yeah.
to this. Why it's not coming, I don't understand. One. Yes.
Okay, brilliant. Fantastic.
So now it's correlated.
You can't see it here, it's off the screen. You have to come here on the monitor to see this. Okay, you have a reproducible response here. Okay, so you've got the two responses here, superimposed. This is about 30 milliseconds. We're losing the 0. It's clear on there. I don't know why we're missing half the screen on this.
So now it's coming. Now
It's coming? Oh, good, there you go. So this is a beautiful response, a P13 response, specific to secular function. How much time do we have left? For the OVEMP. So we'll do the OVEMP now. So like we said, this is specific to secular function, inferior vestibular nerve, and also the lower parts of the brainstem and upper cervical spinal cord, the latter two locations if you're interested in the neurological aspects as well. So we can keep the ear the same and record below the left eye. So for the OVEMP, right ear stimulation, left eye recording, because the OVEMP is a crossed response. Well, the OVEMP, it worked with the CVEMP earlier, so we'll see what the OVEMP does. The problem was we had artifact, 50 hertz artifact with the OVEMP, so we're thinking maybe it's the room or the position of the patient, so we'll see. So any questions with regards to the CVEMP that you may have? Okay. Well, are we stimulating the right here? Okay, all right. I don't know if that's a bit too low. You might need your other electrodes. Yeah, it's too big. Yeah, it's too big. Yeah. So you do need to find the orbital ridge. So you need small electrodes because the sticker ones that we had will be covering the eye. So we need to have the active point of the electrode right on the bone here on the edge to get a good recording. Is it tape? Okay, all right. And then the reference below that. Yeah, the reference below that. Okay. Actually, sorry. It's actually a bit lower than, let's do it like this. There's better. Okay, all right. And the reference below that. Okay. Okay. Oh. No, I shouldn't touch the other one, no. Okay, all right. Okay, just checking the impedance as usual. And the red will be high this time because you're not using it. Do you have to use the red for it to work?
Yeah.
You have to use the red because you're not using it. It's okay, it'll work. And it'll work like this? Okay. Okay. It'll work here. So the reason it didn't work last time isn't because we didn't use this for the OVEP. It's okay. All right, okay, all right. Okay. So, yeah. Yeah, but if the 40 doesn't matter, then the rest is okay. It won't work. Okay. Two ready? Okay, so look up. Look at my finger. Yes. Okay, start averaging.
Yeah.
Look up, 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 further up.
It's not coming.
Okay, relax. It looks like you're getting 50 hertz again.
So now it's came. Actually, a lot of artifacts are.
Sorry? Oh, there was no sound.
95. 1 minute, 1 minute. So 1 minute, give me 1 minute. Okay. I have stimulated right here. So how it will come? You have to choose left. Yeah. Now it will. One minute. Give me 1 minute, sir. No, again it's showing right here. So give me 1 minute. Yeah. Now, okay. No.
Okay, let's try again. So look up. Look up, look up. Relax. I think it's 50 hertz. Yeah, it's 50. This is 50 hertz. It's clear.
1 second, bro. 1 second.
Sorry?
We'll check the graph. We'll check the graph.
Well, check it, but it looks like 50 hertz.
Yeah, it's like a 50 organ.
Yeah, it's 50 hertz.
It's 50
Yeah, so we're not picking it up. So you're sure that we don't need this? Okay, all right, okay. Yeah, okay. We're getting the same problem. The artifact perhaps in the room is affecting the OVEMPs for some reason. Yeah, put the opposite, just to make sure. Okay, all right, it's just that, so it's not 40 hertz.
Yeah, left ear में आएगा वो. Start.
Have you checked the impedance?
Impedance.
Okay, all right, it should work. It should work. If there's no artifacts in the room, it should work now.
So the left ear activates gold. So we'll right here, right.
So
The left ear impedance is good. Left activates. But you will change the
So you want to stimulate the right ear now, yeah? So we have to record from the left eye, yeah? So we have to move the reference to the other side.
That's what I'm telling.
Yeah? Okay. So, yeah?
We'll try 1 second.
So,
It'll come. Yes, sir. We'll start. We'll start. Yeah.
Is there sound?
Sound is coming. Yes.
Okay, all right, just a moment. Okay, all right. So, have you started? No, just a moment. Stop for a second. Stop for a second. Erase it. It's erased. You start from 0. Okay, look up. And so this is the activation procedure. The patient has to look up directly. Now, this is wrong. Okay, do not look to the side. Okay, look up, straight up. If the patient looks to the side, you lose the waveform. Okay, so look up. Just keep looking up.
We'll start.
Okay, stop.
So we'll start.
You're starting now? Okay, look up. You started averaging? Okay, stop. Yeah, sorry. This is the new recording?
Yes.
It's 50 hertz. Yeah, it's 50 hertz.
All are 50.
Okay, so unfortunately we're not able to record OVEMPs here. We couldn't record an OVEMP in the previous study. Very likely it's because of this room here. It's not designed to do an evoked potential. Something very rare. Demonstration. So it's something very rare, but it can happen. That's why you need to have a shielded room. But the CVEMP was very good. The OVEMP appears to be more sensitive to the room. Yes. As much as they can. As much as they can. Yes. Yes. No, no. The difference here, why do we ask the patient to look up? Because the inferior oblique muscle is coming closer to the electrode. So the more the patient looks up, the more they comes closer to the electrode. The CVEMP, the problem with the CVEMP is that there are other muscles. And when they contract the muscle more than they should, they are contracting other muscles. I haven't read this before, but it's possible theoretically, if you like, if you agree with me, that when you contract the neck more, the sternocleidomastoid muscle is not needed anymore and the other muscles come in. Perhaps, perhaps. But clearly, too much contraction is not good. For the OVEMP, you need maximum contraction to bring the inferior oblique muscle to the surface. Yeah, yeah. Any other questions? Okay, thank you very much. Thank you.